Hello, so today we'll revise pharmacology, again CVS pharmacology, but this time it will be calcium channel blockers. So this is just for my private use, but it's anyone can watch it if they want to. So calcium channel blockers, the mode of calcium channel blockers is written in the name. It blocks the calcium channels and it blocks the L type of calcium channels. So the L type of calcium channels are located on the cardiac muscles and the smooth muscles of blood vessels. So there are other types of calcium channels such as T type calcium channel, N type calcium channel, and P and Q type calcium channels. So the T type calcium channels are present on the neurons, and if that channel is these channels cause absent seizures. So the drug that will be used to block these channels will be ethosuximide and valproate, which are anticonvulsant drugs. N-type calcium channels are also present on neuron, but they lead to pain. So we use ziconotide, which is a painkiller, which blocks the N-type calcium channels. P or Q type calcium channels are also present on neurons and they inhibit GABA release. So, pregabalin and gabapentin are the drugs which block these calcium channels, and these are pretty well known drugs in seizure disorders. Now there are types of calcium channel blockers, which is the DHP type and the non-DHP type. So what is the DHP type? Like, as we all know, the drugs that end with dipene, like which are most commonly used, like nifedipine, amlodipine, and those are the DHP type drugs. These drugs end with dipene. So example of it is of course amlodipine and nifedipine. They only act on the blood vessel, the channels that are present on the blood vessels, and are dilators of the arteries. So they can also lead to reflex sympathetic tachycardia. So that is why dipines are always combined with beta blockers when they are given. And dipines don't have any action directly that is on the cardiac muscles or on the heart, but it only acts on the arteries or on the blood vessels. Now there are non-DHP type of calcium channel blockers like diltiazem and verapamil. So diltiazem directly acts on the heart and also acts on the blood vessels. Verapamil acts mainly on the heart, but it also acts peripherally on the blood vessels. Both of these drugs they block the SA node, so they'll cause bradycardia, and they block AV node, so they can cause AV node block. Non-DHP type is absolutely contraindicated in sick sinus syndrome where SA node is affected, and like they can be compounded bradycardia, and also contraindicated in second to third degree heart block because they also block the AV node. So beta blockers also have the effect of blocking the SA node and AV node. So that is why they are never given with non-DHP type of calcium channel blockers like diltiazem and verapamil. They are never used with beta blockers. So let's study about verapamil. So verapamil is the most cardio-specific calcium channel blocker. So it works on the L-type calcium channels that are on the cardiac muscles. So they are responsible for SA and AV node block because it is the most cardio-specific and it prefers working on the heart directly compared to the blood vessel. And the uses for verapamil is in SVT or supraventricular tachycardia, angina, and hypertension. In hypertension, it is used because it is also an artery dilator. Even though the action on the blood vessel is not the main action, it also acts on the blood vessel secondly. So it also works as an artery dilator. So it can be also used in hypertension, but it is not the preferred drug. In SVT, there's supraventricular tachycardia, there's flutter and atrial fibrillation. So, verapamil is given to prevent supraventricular tachycardia from becoming ventricular tachycardia by blocking the AV node. So, as the AV node is blocked, the the tachycardia component will not spread from the uh, atria to the ventricles, and if the SVT becomes a ventricular tachycardia, it is very harmful. So as verapamil blocks the AV node, the spread of it is limited. uh, Angina, so it also inhibits SA node as it is cardiospecific, so it will reduce the oxygen demand of the heart. So it is also used, verapamil is also used in angina, and of course in hypertension because it is an artery dilator. Verapamil also blocks N-type calcium channels. So we read about N-type calcium channels just 2 pages ago, and it is present on neurons, and they lead to increase in pain. So this verapamil can also block the N-type calcium channel like the other drugs, like ziconotide, which was a painkiller. So verapamil can also be given in treatment of migraine headache and cluster headache. And flunarizine is a calcium channel blocker that can be only used for migraine. Flunarizine. Okay, so that is just an extra tidbit. So, what are the properties of verapamil? So, the route of action of verapamil is by intravenous injection or by oral route. So, it inhibits the cytochrome enzyme CYP3A4, which leads to increase in toxicity, because CYP3A4 is like very crucial for detoxification of certain chemicals, and it inhibits the P glycoprotein also, so there will be increased toxicity to digoxin. P glycoprotein is a transporter, and it removes, or it is responsible for the excretion of digoxin via urination, via urine. The side effect of verapamil is vasodilatory headache, and the second most common is constipation. So now let's study about the second non-DHP type, that is diltiazem. So first it is used in angina, then it can be considered in hypertension, and it can also be considered in supraventricular tachycardia. So the three uses of both the non-DHP type drugs are same, but supraventricular tachycardia is the first. Verapamil is the first choice, first used in SVT, then in angina, then in hypertension, least preferred in hypertension. But diltiazem is the most preferred in angina and the least preferred in supraventricular tachycardia. Diltiazem is also similar to verapamil, that it is a CYP3A4 and P glycoprotein inhibitor. So it will also increase toxicity and increase digoxin toxicity because of diltiazem. It has the same side effects of vasodilatory headache and also causing constipation. So uh, this is just a small table, like it's just a small fact, like for SVT, supraventricular tachycardia, will prefer non-DHP type calcium channel blocker, that is verapamil. For angina, will prefer diltiazem, but if there's hypertension, we'll consider dipines like amlodipine, nifedipine, nicardipine, and like many dipines. Now let's come to the biggest category under CCBs, that is dipines, the DHP type drugs. The so first, they are artery dilators, so they are used in hypertension, and they are the drug of choice for PVD. PVD is peripheral vascular disease. So like it will be used in Raynaud's disease, vasospastic angina, and pulmonary artery hypertension, or PAH. Nifedipine is the first drug in this class that was found, and its route of administration is, it is given orally. So there is sudden, rapid, or erratic absorption in the GIT, which will lead to sudden vasodilation, which can lead to reflex tachycardia. And reflex tachycardia means there will be an increase in oxygen demand of the heart. There will be an increased risk of angina, arrhythmia, or myocardial infection in the person. And if there is a sustained oral preparation, there will be a slow and gradual absorption, so there will be slow vasodilation, which means there is a less risk of reflex tachycardia. Nifedipine can also be given intravenous and subcutaneous. So it is used by those routes because basically we know that intravenous route is preferred when you have to give a drug in emergency and you need a faster onset of action. So IV or subcutaneous route can be given in treatment of hypertensive emergency. Nifedipine can be given IV or subcutaneous in treatment of hypertensive emergency, but there will be a side effect of hypotension because it will decrease the BP very rapidly, so the patient can go into hypotension directly. Now let's study about another drug in this class, that is amlodipine. So amlodipine is the longest acting oral drug and it has the least risk of causing reflex tachycardia among the dipines. It has a large volume of distribution and it is the liver and renal safe drug, and it does not act on CYP3A4 enzyme, and that is why it has the least drug of causing drug interactions, like bad drug interactions. So the amlodipine is considered a drug of choice for the long term treatment of hypertension. There is another dipine I said, that is nicardipine, and nicardipine is given by IV and it is the longest acting drug in IV form, and that is why nicardipine is the drug of choice over for hypertensive emergency over nifedipine. So that is why nicardipine is the drug of choice for hypertensive emergency. Clevidipine, it is the shortest acting calcium channel blocker. It is also given IV and it is the shortest acting because it can be metabolized by plasma esterase. So esmolol is the shortest acting beta blocker also because it is also degraded by plasma esterase. That is just a little fact I wanted to know, because plasma esterase degrades clevidipine, so that is why it is the shortest acting CCB, but it also degrades esmolol, which is the shortest acting beta blocker. And clevidipine is also given in hypertensive emergency along with beta blockers, but still the drug of choice for hypertensive emergency is nicardipine. Okay. And nimodipine is a cerebroselective calcium channel blocker and it can cross the blood brain barrier or the meninges, so it will cause cerebral vasodilation, and that is why nimodipine is a treatment for cerebral vasospasm, so like subarachnoid hemorrhage or intracranial hemorrhage. So if there is subarachnoid hemorrhage or intracranial hemorrhage, the drug of choice will be nimodipine. Now there is phenodipine, which is also sustained or extended release preparation, and there is nitridipine, which increases nitric oxide, and nitric oxide has an anti-atherosclerotic action on our blood vessels. And then there is penidipine and isradipine and lercanidipine, and these are also used in treatment of hypertension, but the most important one will sum it up should be nicardipine is the drug of choice in treatment of hypertension. IV nifedipine and subcutaneous nifedipine can also be given in the treatment of hypertension. Clevidipine is the shortest acting calcium channel blocker given by the IV route because it is acted upon by plasma esterase. And similarly, esmolol is a beta blocker, which is also the shortest acting beta blocker because it is also degraded by plasma esterase. Amlodipine is a renal and liver safe drug, and it has the least drug interaction because it does not act on the CYP3A4 enzyme. Amlodipine is also the longest acting oral drug, and it has the least risk of causing reflex tachycardia, and that is why amlodipine is a drug of choice for long term management of hypertension. So let's see what are the side effects of calcium channel blockers. So the most common side effects of calcium channel blockers is headache, and secondly it will also cause urinary retention. So the side effect can be remembered by: there will be flushing, there will be an edema, so it will cause ankle edema, which is like most commonly, which is the first sign of edema. It will reduce the blood pressure of the person, so the person will go into hypertension. There will be gastroesophageal reflux disease, and it also acts as a tocolytic, and tocolytic is something that relaxes the uterus during child delivery. So like there will be less contractions of the uterus, and of course they also cause constipation. So what are the antidote if there is a calcium channel blocker toxicity in a person? We'll give calcium gluconate. So what are the advantages of using calcium channel blockers over beta blockers? So calcium channel blockers are safe to use in asthmatics, but beta blockers, they cause bronchoconstriction, so there is an increased risk of asthma. Calcium channel blockers, they do not worsen diabetes mellitus, but beta blockers are bad for diabetes mellitus. Uh, Thirdly, calcium channel blockers, they also do not worsen dyslipidemia, but beta blockers are bad for using in patients of dyslipidemia. And the fourth thing is the drug of choice for peripheral vascular disease like Raynaud's disease and vasospastic disease and pulmonary artery hypertension is calcium channel blocker, but beta blocker are bad for use in peripheral vascular disease such as Raynaud's disease. So this was a really small, not a really small, it is a small topic, but it is as important. So I'm done with the topic, and of course this is for personal use, but if someone finds it helpful, I'll be thankful. So thank you for that.